So my name is Chris Hall. I'm the program manager for the Interprofessional Education Collaborative. And as you know, that the collaborative is faculty working together to bring you extracurricular opportunities to learn about from and with each other and to engage in some important interprofessional conversations. All right. Well, without further ado, I'm going to turn this over to the public health team here who are going to talk to us about STIs and guide us through some difficult conversations.
This one? Take this one? Okay. Good afternoon, everyone. My name is Shawn Peterson. Thanks for being here today. I'm just going to do a quick round of introductions, and then Kim and I will kind of circle back and talk in a little bit more detail about what we do. If you absolutely do not want to move from the side to the middle, that's like a hard no. At least come down and get the paperwork that's on the seats, because we will use it pretty quickly starting off. And then just a couple of small housekeeping things. The table that has no food on it is also exciting. It has condoms and lube on it. It has some handouts about India Street. It has some information about the needle exchange program. It has CDC treatment guidelines. There aren't duplicates of everything, so I apologize for that, but if you can at least take a look, or if there's something in particular you really want, just snap a pic and then let us know and we can get you some extra copies. Okay, so again, my name is Shawn.
Hi there, everyone. My name is Kim Meehan Brown, and I work at City of Portland Public Health Clinic on behalf of the Maine CDC.
Hi everyone, my name is Kristine Jenkins and I'm a public health district liaison with Maine CDC, and I work for all of Cumberland District, which is Cumberland County. And my counterpart for York County, Adam Hartwig, is at the Biddeford location today where the simulcast is happening. I just wanted to point out to you that on that table in the back there's an annual report from the Cumberland Public Health District. That's a coalition of public health stakeholders that meets every other month here in Cumberland. It's open to students. If you're interested, pick up one of these or just come and talk to me. We'd love to have you there.
And then also joining us today is Dr. Christina DiMatteo over here on the right. She's the medical director for India Street for the STD clinic, and she's also doing a presentation for the CUP program a little bit later. Is it this month or next month? April. Okay, great. So we'll go ahead and get into it. After Kim and I talk a little bit more about what we do, we're going to use the first piece of paper on your chair.
Great. So I don't know how many of you had the opportunity to read this article, Hunting a Killer, Sex, Drugs, and the Return of Syphilis. It really is a great example about the work that disease intervention specialists do. Disease intervention specialists work on behalf of local and state health departments, and our goal is to really break or stop the transmission of sexually transmitted infections. How it works is I receive labs of folks who test positive for chlamydia, gonorrhea, syphilis, HIV. My work when I receive one of those labs is to follow up with the healthcare provider and figure out what brought that person in for testing. Did they have symptoms? Was it a general screening? Had they had a partner test positive? Also to follow up and find out what other testing was offered to them at the time, whether or not there was an HIV test offered, syphilis test. And it's also a great opportunity to step in and help offer provider information. As we get going, we'll talk more about, the importance of people being tested at extragenital sites, how often people should be offered HIV syphilis testing. Also to inform providers or give recommended treatment guidelines if for any reason a person was not treated correctly. Once I finish up and get my provider information, my next step, and sometimes the trickiest part, is contacting the patient who tested positive. It's always kind of strange to get a phone call from a person you do not know inquiring about what, private health information. But once I explain who I am and reporting requirements and conditions, oftentimes folks are pretty willing to talk with me about reason for testing. And at this time, it's always an important time to be able to offer information and assurance. Number one, I always want to know how the person did with the medication. If they went in presenting with symptoms like a discharge, I want to know if the symptoms have gone away. I want to know if they had any side effects from the medication. I also want to talk about future follow-up, the importance of rescreening. Once again, the importance of having additional testing done. What their plan is for protection against STDs, what their thoughts are, offer information about pre-exposure prophylaxis, talk about condom use, talk about pregnancy plan, really anything that comes up during the conversation. The next piece from that, and a key piece where it really is helping to break the chain of disease spread, is talking with people about who their sexual contacts are and offering what we call partner services, where we offer to call partners, locate partners, inform them of exposure, and help to arrange and provide testing and treatment. There are currently 2 disease intervention workers in the state of Maine, only 1 STD clinic. When I first started doing this job, there were several clinics throughout the state, and I think 6 or 7 disease intervention workers. I think a big part of my work that helps it to be more successful maybe in this area, or at least less of a barrier for folks, is I am so fortunate that we have the STD clinic, and I am able to invite folks to come in for free testing and treatment. I don't know, how many of you did read this article? Okay, so a few of you. So some of it is really accurate. I mean, not quite as gritty as the work that's being done in Oklahoma, but I certainly do go out into the community to locate people, offer testing on site, draw blood. This is not totally out of my norm, where I've had folks in my car and I'm doing blood draws, or I meet folks, apartment buildings, alleys, all kinds of places, wherever anyone is willing to meet with me and allow me to offer to test them. That's it.
Okay, so Kim and I operate under the same contract from the Maine CDC, so my position's a little bit different. It's not quite as hands-on as Kim's. It's a community outreach coordinator position for York and Cumberland counties. It's a pretty nebulous job, but basically what we're doing is focusing on testing outreach and then also offering PrEP, pre-exposure prophylaxis, which we'll talk about a little bit later. So we do partnerships with communities like the Levitts Mill Free Clinic. We offer testing there, going out to Bridgeton Hospital, offering rapid testing there. So kind of trying to find some non-traditional locations. We've done testing at Blackstone's. Other CDC staff have offered testing during Pride, down in the park after the parade. So kind of promoting events and opportunities for people to encounter testing sort of outside of a clinical setting. In addition to that, talking to providers and patients about pre-exposure prophylaxis. So when you're doing an intake or someone's testing positive, sort of offering that up as a tool as well, in addition to using condoms and sort of other prevention techniques. We track our own PrEP patients as well. So for those of you that might have followed some of the stuff that happened with India Street Public Health back in 2016, our HIV positive healthcare program closed. And it moved to Greater Portland Health, but the STD clinic and the needle exchange remained at India Street. So we were offering pre-exposure prophylaxis, then we stopped offering it for a little bit, and then we've just started offering it again in October. So we track our patients, make sure that they're coming in for regular testing, and then also talk, like Kim mentioned, to providers about regular testing and treatment options, and getting folks the services that they need. Are there any questions thus far? Just about what Kim and I do? Nope, okay. So there is a piece of paper. Great.
PrEP that you offer free of charge, or is it with a copay and in conjunction with insurance?
Yeah, that's a great question. So we'll kind of skip ahead to like one of my last slides. Pre-exposure prophylaxis is a one-a-day pill. It's Truvada. It's a drug that's also used to treat HIV. And unfortunately, it is really expensive. For folks that have insurance, it's covered by their insurance. If their copay is quite high, Gilead Sciences, the manufacturer, does a copay assistance card that they can apply for. The specialty pharmacies in town, Apothecary by Design and the Maine Medical Center Specialty Pharmacy, do a lot of patient assistance programs, and they'll help people get connected to a copay assistance card. In addition, if someone is uninsured, there's like a whole separate program called Advancing Access for folks that have no insurance whatsoever. And I think we said if you make, was it under 60,000? If you make under 60,000 and you're uninsured, Gilead Sciences will cover the full cost of the medication. So yeah, great question, because paying for Truvada as PrEP could be a tricky part to getting connected to it. Anything else? Nope. Okay. So the piece of paper that's on your seat is a self-assessment form. We have self-assessment forms for males and females. It really doesn't matter which one that you have. It's to give you an idea of what folks see when they come into clinic. So we're just going to give you guys a couple of minutes to kind of read through. You're welcome to answer taking on a different persona, imagining someone that would come to clinic. If you'd like to answer as yourself, you're more than welcome to if you're not having any symptoms. It's more important that you kind of see what folks might be thinking about when they're coming through. So starting with what brings you to clinic today, read through all the questions, and then flip it over, and there are more questions on the back. And I just kind of want to get your feedback and talk about this, and we'll keep this in mind as we move forward and get to the actual sexual history intake form.
Do you have one too? Do you have one?
I don't know if you guys want to fill them out.
Oh. Where are your social workers?
I don't know. They just come and see them.
Yeah.
Yeah, I mean, the ones that I've covered, we've had like 15 social
Yeah.
workers here. I'm surprised they're not here. But it could be
One
that.
student in Biddeford.
No, the usual crew is in here.
All right, great. So imagine you at least had a chance to look at the front, if not both sides. Anything stand out to anyone in particular about any of the questions? Is this what you would imagine a self-assessment form might look like at an STD clinic? As Kim mentioned, we're the last remaining public STD clinic in the state of Maine.
Yeah, cut out at one point, sorry. Put something
Yeah?
in that one.
Okay.
It's all right. Well, we'll just
Okay, so kind of moving on, keeping that in the back of your mind, why are you here? I'm sure some of you were required to be here, so thanks for joining us. Maybe for others, the free lunch was a big sell. For those of you that are really interested in STDs and what we're doing here, I hope you get a lot out of this. We're going to touch on a couple different professions that really might encounter STDs. You know, when you're not working in a specialized STD clinic, right, there are other things going on with people other than STDs. So while you're here, what might you see in your practice that we, you know, are used to seeing kind of on a daily basis? Okay. So for dentists or dental hygienists, people that are actually literally looking into someone's mouth, it's a little bit difficult to see here. But in the center here, does anybody have any idea what that might be? Yeah, thank you. It's syphilis, right? So if you're looking into someone's mouth and you're seeing an open sore or lesion, keeping in mind the signs and symptoms of other STDs and what that could potentially be. So this is a syphilis sore on the kind of like the back side of someone's throat, top of the mouth. Other things you might see inside someone's mouth, other symptoms are herpes simplex virus. You might see little bumps inside the mouth for that. You might also see signs of human papillomavirus, HPV. Is everyone familiar with HPV? Okay, so that's also transmitted orally. You can have signs and symptoms orally as well. Right, so if you are a dentist or a dental hygienist, being aware of the signs and symptoms of some of the most common STDs at least prepares you to talk to your patients about like, hey, I'm seeing something here, I just want to check in. You know, when was the last time you saw your primary care doctor? You know, it doesn't even have to be like, hey, I think you have syphilis, right? That's maybe not a great starting point for having a conversation with someone if you're seeing something that you're not sure about. So moving on to a pharmacist. So someone who's maybe not working clinically directly with patients, but that might be filling scripts for things that we call in, or that another provider might be calling in. So we have called in prescriptions for azithromycin, which is used to treat chlamydia, and in conjunction with ceftriaxone used to treat gonorrhea. Right, so as a pharmacist, if you're filling scripts for someone, you know, maybe being prepared to answer some basic questions. Of course, they should be getting all those questions answered by their provider, but we know that doesn't always happen. Right, or if someone is there filling a prescription for PrEP, kind of as someone asked in the back, if someone's filling a prescription for Truvada as PrEP, and then all of a sudden they're charged a $500 copay, and they don't know what to do about that, having a little bit of information on hand about patient assistance programs can really help you in your job, helping that patient, and also help them get on a medication that, you know, they're actively trying to be on to prevent the transmission of HIV. Is anyone here from pharmacy? Remember? Yeah? Okay, great. Has anyone kind of looked at apothecary by design models or Maine med specialty pharmacy models, and there's sort of that idea of being a patient navigator and helping folks access some of those programs? No. So there's a lot out there, and that's, I would say, a lot of what we do is helping to connect people to services outside of India Street. And paying for PrEP is definitely a big one, especially for folks that are uninsured. Kind of getting through all the hoops of filling in all the paperwork and getting everything done properly so they can start that medication, it can be a high barrier, and you being able to assist them can really make a huge difference. So then obviously also the increasing rate of STDs. So we're gonna go over all the rates for Maine, but in Maine and nationally, pretty much everything went up. The 4 reportable conditions we're gonna talk about today are chlamydia, gonorrhea, syphilis, and HIV. So we'll go over the rates, but everything in Maine went up from 2016 to 2017, except for HIV. Any ideas on why STD rates are increasing? Yeah, so potentially there are fewer clinics open, or the clinics that are open have fewer resources. Yeah, less education on safe sex. I don't know about where everyone grew up necessarily. I grew up in California, and sex ed was like all over the place, left, right, and center. Right, so state by state, it's really different too, the education that kids are getting.
There's a proportion of the elderly population that do not feel the need to use protection since they're at an age where they can't get pregnant.
Yeah, great. Yeah, so syphilis is on the rise, not just in young people, right? Viagra is also a huge contributing factor. Any other ideas? Yeah?
That all of these diseases have been contained or eradicated and don't have to work.
Great, so the idea that these are all gone, right? Like, I don't need to worry about that. That's not a problem anymore. Anything else? Yep, in the back.
Drug use and not being able to make good decisions in the moment.
Great, so okay, impaired ability, right? Maybe not using condoms because of substance use or other things like that. We'll come back to substance use when we get to one of our other forms as well. Yes. Great, yeah, so kind of the same, a little, yeah, kind of cutting public health infrastructure in general. I'm surprised no one mentioned dating apps. Yeah, yes. Right, so there's no one factor.
Don't let Julia do it.
Okay,
you said like a mixed bag of things that have kind of led to an increase, and separating one out from the other is probably not going to get you anywhere. But definitely connectivity, right? Like it's easier to find sex partners. We used to do some advertising on Craigslist for our services, and I don't know if anybody heard, but they recently had to shut down their personal encounters section of their page because of some rules and regulations around sex trafficking. So it sounds a little bit strange, but Craigslist is a great anonymous place to meet sex partners. A lot of folks that utilize Craigslist can be higher risk because of the anonymity. And that was a place that we were advertising. I believe even Franny Peabody Center, who also offers testing, was doing a little advertising on there. And that was also a great way to reach people that are looking for sex partners.
And, you know, as Shawn was saying, the dating apps, as someone who tracks disease and looks for partners and contacts, the dating apps have made it more difficult for DIS to be able to find patients because there's not always good locating information. People might not save emails, whatever, to help the DIS locate partners.
Okay, so getting into a little bit of the data here, we're going to start with chlamydia and gonorrhea, and then Kim's going to take over and talk about syphilis and HIV. So just starting a little bit with the numbers here before we get into symptoms and treatment. So last year, you know, about 4,100 cases in the state of Maine, predominantly female. And then you can see down at the bottom there, the 2017 number is about 4,551. So an increase definitely from year to year. Any idea where we are? We actually don't have data through March, but I have data for January and February of this year. Any guesses on the number of chlamydia cases for Jan and Feb of 2018? Just yell a number. 300? 600? Oh, 601. It's like 603. Really spot on. Yeah, excellent. So some of the bad news about chlamydia and gonorrhea is that it is often asymptomatic, especially in women. So kind of a bummer. You know, you think you don't have an STD and then you might. I stress that here really because getting tested is so important. A lot of people tell us, like, I would know if I had an STD. And it's possible you might. You know, some of the signs and symptoms for chlamydia and gonorrhea, a discharge, discomfort, or like a little bit of burning sensation when you're going to the bathroom, you definitely might have that, especially gonorrhea for men, having like a yellow or green discharge from the penis, right? That's a really obvious symptom. But for some people, you may not have symptoms at all. Right, so getting tested regularly, even if you only have one sex partner, but definitely if you have more than one sex partner, is really important for catching those infections. The treatment for chlamydia, which as Kim mentioned, we offer at the clinic, is 1 gram of azithromycin. So folks can take it right away. We have snacks on hand, so they're not taking it on an empty stomach. You might be familiar with azithromycin if you've ever had a sinus infection. It's the same antibiotic that's in a Z-Pak. All right, so gonorrhea, much lower numbers. This is also reflected nationally. So about 450 cases in 2016, and then a pretty significant jump in gonorrhea last year to 577. Any guesses for Jan and Feb of this year? Shows 2 months. 56. 71.
I had 202 over here.
202, I like the really specific numbers. All right, so for gonorrhea, we're at 107. All right, so it's, it adds up quickly, which is really kind of the amazing part. So Kim, as a DIS, gets these reports every month, and it is interesting as we sort of track and go through our clinic, also look at positives to kind of see where the state is. The Maine rate is still lower than the U.S. rate, so we're not looking at numbers that are as large. The population is much smaller than Maine, but these are still significant numbers, again, that are sort of continually moving up and something to keep an eye on. So again, often asymptomatic in folks. We used to do gram stains at clinic, but we don't right now. But if someone were to have a discharge, you could actually put that on a slide, and in our lab we could look at that. The green-yellow discharge in men is often how male patients know that they have gonorrhea. Again, in women, it can be asymptomatic, or it can feel very similar to a bladder infection, or have some similar symptoms to chlamydia. So again, really stressing that you're getting tested, and that you're getting tested for both when you go to your provider. If you come to India Street, it's kind of a blanket, you get tested for everything. We're really big on the comprehensive testing because infections travel together. Any questions on chlamydia or gonorrhea, how it's transmitted? Gonorrhea is treated with an additional drug to azithromycin. It goes with ceftriaxone. So if you're getting treated for that, you would get 1 gram of azithromycin and then a shot in the butt for ceftriaxone. And they have to be given at the same time.
My question about the numbers, these are new diagnoses, but anecdotally, are any of them reinfections?
Definitely. Yeah, absolutely. Yeah, so reinfections do happen. Whenever someone gets treated, all of our patient information forms, which I didn't actually print out, really stress not having sex for 7 to 10 days. You don't want to be in the chlamydia circle, right? Where like you get treated and then 2 days later you have sex with your partner, they get infected, and then you're passing it back and forth, right? So really making sure that you've cleared the infection by sticking with the 7 to 10 days, making sure you've cleared it before having sex with your partner again is important, but also getting rescreened. So when folks come in and test positive and get treated, we do encourage them to come back 3 months later and get rescreened again. Any other questions about chlamydia and gonorrhea?
So I am going to chit-chat a little bit about syphilis. And I think the one thing I've learned is the more time I spend doing DIS work, and even with, the more cases of syphilis that we encounter, I always learn more and more about syphilis all the time. So this quote is great: "He who knows syphilis knows medicine," because syphilis can present with so many other symptoms and manifestations that it can very easily, depending on the staging, be diagnosed as something else, and the actual syphilis infection can be missed. So basically, syphilis is a sexually transmitted disease caused by the bacterium Treponema pallidum spirochete, which is basically a corkscrew-shaped bacterium. And it's been known as the great imitator because of, like what I said, depending on the staging, its symptoms can mimic other infections or diseases. However, the one thing about syphilis is it will oftentimes follow a progression of stages that can last for either weeks or decades if left untreated. The initial infection occurs with direct sexual contact with the bacteria, which once it enters the system, spreads all over the body using the blood vessels and the lymphatic system, and it multiplies pretty rapidly. So syphilis is broken into different stages. The first stage is known as the primary stage. And in the primary stage, a person might present with sore lesion known as a chancre. There can also be like multiple sores. Oftentimes, syphilis has been thought to be painless, but sometimes people do experience pain with the primary lesions. The chancres can occur and do occur at the location where the spirochetes directly enter the body. So you'll have a chancre maybe in your mouth, vulva, vagina, rectum, but because syphilis can be so very sneaky, you can end up having it in a place where you don't see, like inside of the vagina, inside the rectum, inside the mouth, under the, I had one guy who had it under his testicles and did not realize that it was a primary lesion. He had thought he had got caught in a zipper. So the chancre usually lasts from 3 to 6 weeks. The normal time period that I've seen when I've interviewed folks with primary syphilis, that they usually will develop the lesion within a 21-day time period, but not always. And the lesion will heal regardless of whether you get treated or not treated, the lesion will heal. And if untreated, you will move on to the secondary stage of syphilis. Signs of the secondary stage can appear, while you have the primary lesion or after the primary lesion has healed. So symptoms usually can occur, symptoms of syphilis usually are a rash, and they can occur and last like 1 to 6 weeks, with the average being about 4 weeks. So signs of secondary syphilis can be skin rashes. You may have a rash on your torso. You may have a rash on your hands and feet, which is really a classic symptom of syphilis, palmar plantar rash. However, oftentimes what can happen is you can have a non-itchy red rash that might be very, very faint, so you might hardly even notice it. Or you can just think or be told when you go and get it checked out that, you know, you have like pityriasis rosacea, tinea, I'm trying to think what else, dermatitis. It can look like a heat rash. And once again, regardless of whether or not you are treated or not treated, the rash will resolve itself. Another classic sign or symptom of secondary syphilis is these large gray, white, painless wart-like lesions that will appear in warm, moist places. That's known as condyloma lata. Thank you. Which they tend, like I said, they tend to develop in warm, moist places like in your mouth, underarms, genitals. And these lesions hold a really high concentration. They're just teeming with those spirochetes. So this is another incredibly infectious stage of the disease. What we've sometimes seen is that these lesions could potentially be diagnosed as human papillomavirus. So anytime these signs, you see people with either primary signs, secondary signs, it's always great to keep, you know, the differential of syphilis in mind and think about running and offering a syphilis test. We'll talk more about testing as I go through it all. Other signs of secondary syphilis can be a sore throat, patchy hair loss, headaches, weight loss, fatigue, and left untreated, the person will move on to a latent stage of syphilis. And the latency period is divided into two sections, which is either early non-primary, non-secondary. This is when a person does not have any signs or symptoms of the infection. However, they have been tested within the last 12 months. So they have a recorded test. The second latent stage is known as unknown duration of late syphilis, which is basically saying the person's asymptomatic and the infection occurred over a 12-month time period. There's no documented test on record, they're asymptomatic. Without treatment, syphilis can enter the tertiary stage. I think it's like 10 to 30 years later, folks can present with signs of tertiary syphilis. I have never encountered an individual diagnosed with tertiary syphilis, but what can end up happening and some of the side effects can be dementia, let me take a few, dementia, vision impairment, loss of memory, coordination, those sorts of things. Other components or pieces to syphilis infection can be neurosyphilis, ocular syphilis, and congenital syphilis. And you know, when I first started doing this, I thought, oh, neurosyphilis can only happen if a person has been infected for a really long period of time. This must be like the latent stage. But no, neurosyphilis can happen at basically any time during the infection. A person can just recently be infected in a secondary stage and have symptoms and be diagnosed with neurosyphilis. And once again, the very same thing with ocular syphilis, where it can be a new infection, but the person is presenting with, you know, blurred vision, uveitis, vision loss, and a diagnosis of ocular syphilis is made. Congenital syphilis is transmission from mother to baby. And so far in Maine, and I really do want to knock on wood, we haven't had any cases of congenital syphilis, at least since I've been doing this work. And I'm hoping that that stays true. But even within the past 12 months, I have worked 3 pregnant women who have tested positive for syphilis. And so if these ladies had not gone off and been tested, you know, there's no knowing really what the outcome would have been for their babies. Syphilis testing. Oh, okay. Let it go. All right. So here are the rates in Maine for syphilis. At the end of 2017, 84 cases. Want to take a guess of what it is right now for 2018? And 27? Anyone else? 35. So 13. So, yay. I'm going to, yay. I just have to say one more thing about syphilis. So there are 2 types of syphilis testing. There's a non-treponemal test and a treponemal test. The non-treponemal test is more of a quantitative test where it's not really looking for the specific antibodies, but it can give you a quantitative measure of like the body's response to the bacteria. And the qualitative test gives you a yay or nay that the person, it's more specific looking for the treponema itself. Syphilis testing and results provided should always be 2 tests. If you have one that's reactive, you want to repeat one of the other ones. All right. Oh, HIV. All right. So, first of all, CDC recommends that anyone between the ages of 13 and 64 get tested for HIV at least once as part of routine health care. Anyone who presents with an STD should also be tested for HIV. Men who have sex with men should be tested for HIV. Pregnant women should be tested for HIV. Basically, I think everyone should be tested at some time and then more regularly for HIV. Really important, the only way you are going to know if your patients are at risk or if you're at risk and need to be tested is to really think about and ask yourself or your patients questions of, you know, have you had more than one sex partner since your last HIV test? Are you or any of your sex partners injection drug users, people who inject drugs? Have you been diagnosed with another STD? Have you been diagnosed or treated for hepatitis or tuberculosis? Have you swapped sex for drugs, money, survival needs? Have you had sex with anyone who could answer yes to any of those questions? Any questions so far? No. And I'm not sure, let me see, all right, so our HIV test numbers have gone down from 2016, 47 cases, 2017, 32 cases. What do you think the number of HIV cases are for as of the end of February? 7. Who said 7? 7? Okay. The actual number, 3. And so I think, you know, what's really fabulous is that, you know, people are engaging in care. A big piece of HIV reduction is treatment as prevention. It's also people taking PrEP. So, all right.
Since we're a little bit short on time, we are going to skip this one. In a nutshell, it's a sexual health network, right? So if you can imagine that you were one of these circles and you were sleeping with someone and they were sleeping with another circle and that circle was, you know, you get the idea. So putting more of the pieces together and kind of moving on to the sexual history intake, we're going to pass out an additional form for you guys to take a look at. So we are paper-based at India Street, as you probably noticed. The self-assessment form that you completed is what someone fills in when they first come in addition to like a basic demographic form, which also includes, you know, information about sexual orientation and gender identity, whether they're insured or not, if they have primary care, if they don't, helping them get connected to that. The form that you're going to get now is the actual intake form that our staff use when someone actually, comes into the exam room. It's only one-sided. In clinic, it is two-sided. The back side is what Dr. DiMatteo uses, so I left it off. It's for making notes about the visual exam and follow-up and other things that are relevant, but we just didn't have time to cover today. So as you get that form, go ahead and take a quick look at it. There are a lot of questions. We recently reformatted it to squeeze more questions into it. Once everybody has a form and has had a chance to at least take a look at a couple of the questions, I just want you to find someone next to you. If there's not someone next to you, reach across the chairs and find that person. And just take a couple of minutes to kind of take on a different persona. Think about someone who is high risk, or maybe someone that is hesitant to be in clinic, or maybe someone who is an oversharer in a clinic, and ask each other a couple of the questions and think about how you might phrase some of those questions and why that's important to think about. So take a couple of minutes, find someone next to you. If you need to move, please move. It is an important part of the activity that you actually verbalize some of these questions and get a feel for what it's like to really have to ask someone some very personal, intimate questions about their sex lives.
This is also the time when the 1 o'clock class is pulling people away.
That's what I was waiting for. You're waiting for that.
Thank you.
You're welcome. We'll get you with the quiz later. I'm thinking I actually know a lot about the men who have sex with men and the meth angle. Because I attended a breakout session at the harm reduction conference.
Yeah, then you can be MSM.
All right, let's do that.
All right, that is fine with me.
If you guys want to move up there, I'll get them to kind of wrap up.
You need a microphone. And you want to, are you going to do questions from the audience or responses from the audience before you go? You have so many microphones. Okay. So,
Hand one up.
yeah, okay. So she's going to do responses from the audience.
So go ahead and start wrapping up maybe the last question you were on, and Chris and Kim are going to move up onto the stage and do a demo of an intake. Before they get started, are there any questions about any of the questions on the intake form, or any one question in particular that was especially unusual or awkward, or that stood out to you as something that you may not have thought to ask? Great, so where are your meeting partners? What is a cruising area? Does anybody know what a cruising area is?
I would assume a cruising area would be where you're picking people up. So if you're picking people up on Match.com, then maybe people on Match are more at high risk. Or if you're picking people up on Congress Street because you're propositioning, then maybe public health workers need to focus in that area to let people know that they might be at a higher risk.
That's great. Yeah, cruising area is exactly what it sounds like, right? It's where it's like a known place in the community that people hang out to pick up sex partners on the spot and usually have sex right there too. So there is an app for that. There's an app for everything. It's called Squirt, and it is an app that will help you find cruising areas in your neighborhood. Any other questions about anything on the intake form?
Oh, sorry.
Does anyone know what Backpage is? Nope. Okay, so Backpage is a lot like Craigslist, but it was really specific for the personal encounter component. Backpage sort of hit the headlines a couple years ago, again, because of issues around sex trafficking. And there are obviously two sides, more than two sides to that. People that use it legitimately and support themselves. You know, that's a real thing, and that's an industry. And then there's definitely a sex trafficking component to it. And so things have changed for Backpage, but the website is still live. You can go take a look at it. Yeah. Okay, pending any questions, I'll hand things over to Chris and Kim.
Perfect, thank you. You ready? Great. Hey there, Matt. My name's Kim. Welcome to the clinic this afternoon.
Hi, Kim.
How are you?
I'm doing all right, a little uncomfortable.
I understand. It's great that you came in. I'm glad to see you. Can you tell me what brought you in today?
Well, I've been partying a little harder than usual, and I'm experiencing some symptoms, and I guess I would just like a checkup, just a quick, checkup.
Absolutely. Well, what we can do today, we can offer you syphilis, HIV, chlamydia, gonorrhea screening, and if anything else, we'll talk more about it as we go along.
Sounds good.
So tell me, what kind of symptoms? And usually I'll take
You're looking at my...
What kind of symptoms are you having?
I just have some sores and some just discomfort.
How long have you had the sores?
A couple weeks.
And where are the sores?
The kinds of friends that I have, we tend to have big parties, and so they're in the pelvic area.
Got it. How long have you had them?
A couple weeks. I'm just noticing like pain, and we've been it's been a long winter, so we've been entertaining ourselves.
Absolutely. Anything else besides the sores, the pain? Is the pain all around your pelvic area as well? Yeah?
Mm-hmm.
Can I ask, have any of your friends that you've been hanging out with, do any of them have any sores or anything?
There's a couple of guys who don't show up anymore, and the word is that they're pretty sick,
Okay.
Which is causing me concern.
Do you know what they're sick with?
I think it's, no, I don't.
All right. So let me ask you, when's the last time you went to the bathroom to pee?
This morning.
Okay. So what we're going to do is I'm going to send you off to the bathroom. I'm going to collect a urine sample. We're going to use that sample to test you for chlamydia and gonorrhea. When was your last STD screening?
Years ago, I
Okay.
think, yeah.
So this is sounds like it's a good time for you to be here. How about HIV? Have you done any HIV testing? Have you stopped by Peabody Center or done any at-home testing?
When I was younger, I did it pretty regularly, but I haven't,
But not for a while.
haven't done it since.
So also, let me ask you, tell me about your sexual contacts partners. How many contacts in the past 3 months would you say?
Well, there's a group of us, like I said, and
A regular group?
a pretty regular group,
Yeah.
and it's kind of a party culture, and
So you guys doing a little party and play?
yeah.
Okay, all right. Tell me about your contact with your folks. Are you having anal sex? Are you having vaginal sex? Are your partners male, female, trans, all of
It's
the
all guys. We're all a group of guys, and it's there's some drug use
Yeah.
as well, and it just tends to all blur together as part of the fun.
Have you been taking any rest time between the partying? Have you had any days off or time off? Are you using daily or weekly or?
It comes and goes in waves. So there's there's a long weekend is pretty involved, but then everybody's got a job, so everybody breaks back out to go to work during the week.
So let me ask you, when was your last sexual contact with anyone? And by sexual contact, I'm really asking oral, anal.
What's today, Wednesday?
Yeah,
Probably Sunday night.
Sunday? Okay. And I know these are your regular contacts, but are any of these folks living with HIV?
I think that it's under control.
Okay, so some folks might be positive but in treatment? Okay.
Yeah.
So would you say yes then, that some of your contacts are HIV positive?
Yeah.
Okay. And how are you guys partying? How are you guys like snorting? Are you guys booty bumping? Are you guys injecting? How are you using your
Well, I
substances?
think by the time things really get rolling on Saturday afternoon, all of those things are possible.
Okay.
The thing about meth is that it makes the sex really great.
Absolutely.
So and we're not inhibited with each other.
Are you familiar with the syringe exchange program that we also have here?
I've heard about it.
Okay, so if you guys are injecting, I would like to get you connected with the exchange. They can give you clean needles, hookers, cottons, ties, and you get to remain totally anonymous. They'll just give you a number, and you can come in anytime to swap dirty rigs for clean rigs. And feel free to share, I know, but feel free to share info with any of your friends as well.
Yeah, thanks. We live and work in this town, so it would be hard to go to something in this town. But
Absolutely.
if there's something in a different town, we might be able to.
So it sounds as though you're working.
Yeah.
Can I ask, are you swapping sex for drugs, money, survival needs?
I have an income, but I don't always buy the drugs myself.
Okay, so are you swapping sex for drugs sometimes?
Sometimes.
Okay. I'm going to ask you about some of the substances, and you can tell me yes if you're using any of them, and then I'll ask you about frequency. What's the main party drug that you guys are using right now?
Mostly meth.
Meth. And would you say you're using daily, weekly, monthly, socially?
Weekly during the weekend.
Okay. And are you using anything else? Are you using poppers?
It's hard to tell.
Okay, all right. Viagra?
Sometimes.
Okay, yep. Any other substances that you might be using or injecting?
It's, sometimes you have to get down to go to work, so, sometimes a little pot.
Okay, daily, weekly, monthly, socially?
Often.
Often, okay, all right. And I know this sounds like a silly question, but are you using meth before or during sex? And
Yes.
Okay. And have you injected?
I haven't.
You haven't, okay. Okay. Have you ever injected?
Few years ago, but I didn't like it.
So, a couple years ago, have you been tested for hepatitis C? Do you know if you've been tested for hep C?
No, I don't know.
So as part of your testing today, I'll offer you a hep C test as well. I can draw it when I draw the syphilis and HIV.
I thought that was like a third world problem.
No, hepatitis C is really, with the increase in opioid use nationally, there's been a big increase in hepatitis C as well. Hepatitis C you can get from sharing. I always like to emphasize sharing injection drug equipment. So you can get it from cookers, cottons, ties. One of the great reasons why you might want to get hooked up with the syringe exchange program. Can I ask you, what's your plan? What do you do to protect yourself from STDs?
Well, I thought just sticking with the regular group of guys would do it.
And that's certainly a way if, you are all, sticking together in the group. Sometimes though people step outside of the group. Sometimes things happen. Any condom use? No. Are you familiar with PrEP? Have you heard about PrEP?
There's been talk, but I don't know any details.
So basically, PrEP is pre-exposure prophylaxis. And so it's a pill that you take daily. I always kind of compare it like birth control for women. If you are interested, we could help maybe get you set up with PrEP today. Part of the deal would be I would need to know whether or not you had health insurance. It sounds like you have a job, but do you have health insurance?
Yeah.
Okay, great. Do you have a regular primary care provider?
Yeah, it's like they're students, so it rotates a lot.
Okay, we would ideally want to make sure you had a primary care provider, just so that we would have someone to follow up with in terms of prescribing you PrEP. What I can do today is we have a great PowerPoint presentation. I can also answer some questions for you about PrEP.
Are there side effects,
So
weight gain?
No, there can be some side effects. Sometimes folks, when they first start taking it, might have a little bit of an upset stomach for a week or two. Most times people clear that. There can be, the doctor will talk with you more about it, but sometimes there can be some issues around bone density. But once again, the doctor can talk with you more about that. Part of what we will do today is we will run a metabolic panel, a blood panel on you. So I'll still draw your blood, 1 needle, 2 tubes, and the information that the provider gets from that panel will help to determine, you know, if there could be any medical concerns about you taking PrEP. It's really simple. You would, you know, would draw your first labs today, would ask you to come back in a month, would draw you another lab for an HIV test, and then part of the deal is, which might be great, is that, you know, you could come in and see us every 3 months for STD screening. Is it something you think you might be interested in?
I might be, but I don't know if I'm up for a daily pill. There's, you know, I don't even take vitamins.
Okay. Something, I mean, what do you think about the benefits of it? I mean, it's a way to help, you know, potentially protect you really from HIV. Are you concerned about HIV infection?
I wasn't until I got here.
And don't tell me you're never going to have sex again. I get that after everyone meets with me all the time. But, you know, we could talk about it. I can give you information. You can think about it. When we call and give you your results next week, if you decide that you might like to come back in and explore it further.
Yeah, let's do it in stages. That's a lot.
Okay, all right. So I am going to ask you a few more questions. You ready? Do we have time?
No.
She's the top one, isn't she? She's giving me a run for my money.
Do you feel as though you've received an adequate demonstration of how to have the conversation?
And we would push for PrEP one more time. She would still go see Dr. DiMatteo. We are not done with this conversation.
Thank you.
We appreciate that you guys have to get going, so we'll continue. For those of you that do want to stay, we have a couple extra slides. There's obviously a lot to cover on a topic like this. Are there any questions for Kim or for Chris about the Sonoma sheet was on, or any of the questions that really stood out to you?
I trust we're in a cone of silence. What was it like for me? I attended a really great session at the last harm reduction conference that was all about men who have sex with men and what meth does in those circles and in that culture, and it was frightening to consider what my point of view really was as she was asking questions, because there's a lot that can go wrong with that scenario.
And I've worked with quite a few MSM taking meth, and yes and no. I mean, sometimes I can get a bit further with people than I thought we were able to get. We would have probably been in the room together for 90 minutes or so, because I would have really wanted to make sure you were connected with the syringe exchange. We would have really talked more about meth, and really just trying to find times for you to rest your body a little bit between use, which is huge for a lot of folks. But when people are really on that hamster wheel, It is so, so hard, and I mean, you did do a great job of presenting that. It is so hard to break through.
Yeah, the immediate benefits outweigh the risk.
So one of the questions that Kim focused in on there was, tell me about what kind of sex you're having, you know, anal, oral, and vaginal. And a huge part of comprehensive testing at India Street and a huge part of comprehensive testing anywhere with STDs really should be including anal and oral testing. So I'm gonna have Kim walk around with some swabs, and then I'm just gonna play a fun Durex condom while she's doing that. Great. So the reason I show that kind of on the heels of what Kim and Chris were just doing is really to emphasize the fact that you have to ask people what kind of sex they're having in order to know what to test, right? So Kim and I are both wearing our if you use it, test it tank tops, and that's probably on top of what they just did is one of the biggest take homes here. If you don't ask, you won't know, right? So the swabs that she passed around are swabs that we use in clinic. The orange one is for vaginal swabs, and there's an additional tube in there for what's called a wet mount. And the sample that Dr. DiMatteo and other providers take then goes under the microscope. The other two swabs that I separated out are actually both the same. They're the white ones, and those are for anal and oral samples. We also offer self-swabbing at India Street, and that's something that any provider anywhere can incorporate into their practice. So really highlighting here that if you don't do the extragenital testing, you're really missing a huge part of the positivity in a community. So there's a slide here and then a following slide from India Street that just show testing at two different places. This was a study from 2010 to 2012. And it shows on the left the total number of folks MSM that were tested, the urine that was tested, the positivity, oral and anal and positivity. And they may not seem like big numbers, but you have to remember that if you didn't test those sites, then you would never get those cases, and that person could still be giving that to their partner or multiple partners. And then finally moving on to some information that Dr. DiMatteo put together. This is from India Street for just over a 12-month period. And so we actually looked at all the positives. And then if you looked at someone who tested positive for anal or oral or both chlamydia and gonorrhea, but tested negative in the urine, in gonorrhea, you would miss 70% of the cases. Right, so again, if you're not testing someone at all sites, then you're not really testing them, especially if they're using those sites during sex, right? Because if you're just having someone pee in a cup, but they're anal positive gonorrhea or oral positive chlamydia, then you've completely missed that opportunity to catch that infection, treat it, and stop it from spreading. I think we'll go ahead and wrap up here because Kim and Chris did a great job talking about PrEP. Are there any last minute questions? I know we went over a little bit. Any burning questions?
Thank you for the presentation. I would like to ask you if there are many antibiotic drug resistant in the STDs in Maine.
Yeah. So we haven't seen any drug resistance in Maine, but there have been cases in Hawaii of gonorrhea only. So yeah, it does happen, and it is something to be aware of. But as Kim was doing, we haven't seen it here in Maine. Yeah. Anyone else? Okay, thank you guys for your time, and thanks for staying a little late. We'll all be up here if you have any questions.
Thank you.